Good afternoon, everybody. I am Dr. Abidin, pediatric hemato-oncologist, Burjil Medical City, Abu Dhabi. I am here to talk about bone marrow transplantation, an overview, what general pediatrician need to know. As you may know, BMT is a well-recognized treatment for variety of childhood condition like acute leukemia or non-cancerous condition like aplastic anemia, thalassemia major, sickle cell disease. In fact, first bone marrow transplantation was reported in children. One of the common confusion among the pediatric doctors is who does the bone marrow transplantation? Is it the surgeon or the physician? We all think that similar to kidney transplantation or liver transplantation, it is usually done by surgeon. In reality, bone marrow transplantation is the only transplantation done by physician. In the case of children, it is done by pediatric hematologist or oncologist or immunologist. Next 20 minutes, I would like to provide you very basic information about different steps in bone marrow transplantation, how it is done, and what are the main indication of bone marrow transplantation in children. So, what is bone marrow transplantation? In simple term, it is a procedure in which there is a transplantation or transfer of healthy hematopoietic stem cell, which is a blood forming cells usually in the bone marrow, to patient to replace diseased blood stem cells of the patient. So then the question is why we call bone marrow transplantation when we transplanting hematopoietic stem cells. So in the past, when this kind of transplantation first started, our understanding was the stem cell we can see or detect is in the bone marrow. So bone marrow from the donor was aspirated and given to the patient. Therefore, we called bone marrow transplantation. Actually, what is happening is transplantation of the hematopoietic stem cell. So now we realize that we can get blood stem cell from the peripheral blood, a newborn cord blood. So we learned that we can do so-called bone marrow transplantation without taking bone marrow from the donor. Therefore, recently the term hematopoietic stem cell transplantation has become the preferable terminology when we explain bone marrow transplantation instead of BMT or bone marrow transplantation. So in this talk, I may use term BMT or hematopoietic stem cell transplantation in between, but actually both are same. So now you can understand that actually what is transplanting or transferring from the donor to recipient in the bone marrow transplantation is not the bone marrow, it is the hematopoietic stem cells. I hope first common confusion about using the terminology is cleared by now. We also use different terminologies, depends on source of stem cell. If the stem cell is from bone marrow, we call it bone marrow stem cell transplantation. Even though we can get stem cell from the peripheral blood and cord blood, still there are many centers, there are transplant physicians use bone marrow as a source of stem cell. If you are using source of stem cell peripheral blood, then we call peripheral stem cell transplantation. If you are using stem cell from cord blood, then we call it cord blood stem cell transplantation. There are other terminology which is important for you to understand. We need to know what is autologous bone marrow transplantation. Autologous bone marrow transplantation means the source of stem cell is patient itself. especially in the case of solid tumors in children like neuroblastoma or medulloblastoma. We use high-dose chemotherapy with stem cell rescue. In that case, transplant physician collect the stem cell from the patient, because in the case of neuroblastoma or brain tumor, their stem cell are healthy. There is no issue with their stem cell. So we collect the stem cell and store. After that, they give very high dose chemotherapy to destroy all the cancer cell remaining in the body. So when we use high dose chemotherapy, patients' healthy, normal blood stem cell are destroyed. That time we reinfuse patient's own stem cell as a rescue, so that this stem cell go into the bone marrow of the patient and they start developing normal blood cells, which include RBC, platelet and WBC. That is why call it as autologous bone marrow transplantation or autologous stem cell transplantation. The other terminology you need to know is allogenic bone marrow transplantation, where stem cell coming from other person. It can be related or it can be unrelated. So other terminology you may hear is haploidentical bone marrow transplantation. In this case, we use stem cell which is 50% match and usually from family donor. So now, as you understand basic terminology of bone marrow transplantation, the another important terminology you may hear when people talk about bone marrow transplantation is matching or matched donor kind of things. So what is matching? Why matching is important and how we do matching? In the case of blood transfusion, as you know, we always look blood group matching before blood transfusion. Similarly, in the case of stem cell transplantation, we use different matching that is based on HLA typing of cells in our body. So what is HLA typing? HLA means human leukocyte antigen. It is a specialized protein present on the cell surface of all the cells in our body except red blood cells. So this protein is controlled by gene located on chromosome 6. Like blood group ABO, HLA also classified as class 1 and class 2. Class 1 is HLA A, B and C. Class 2 is HLA DR, DP and DQ. So each one of them has specific 2 numbers, and so if HLA B, C and DR, DQ, DP, that means 6 subtype, and each one will have 2 numbers, then there will be total 12 numbers. But in the case of bone marrow transplantation, we don't consider DP. Therefore, we will have maximum 10 scoring 10 numbers. So when we talk about matching, we will say 10 match out of 10 or 8 matched out of 10 or 9 matched out of 10. So it is a kind of scoring system. So a well-matched donor defined as either 9 out of 10 or 10 out of 10 match in the case of bone marrow transplantation. Mismatch means 6 to 8 out of 10. So why matching is important? The best match gives us the best outcome. If If less match between donor and recipient, that means the chance of graft failure or complication like GVHT are high. Therefore, always our aim is to get the best match between recipient and donors. So how HLA typing is done? There are two methods. One is called low resolution. It is a antibody based test, serological test, and other thing is high resolution test. It is done by gene sequencing, and usually the best test and always recommended test is high resolution HLA typing, so that we will know correctly the HLA of recipient as well as donor, they are matched or not. Therefore, a good collaboration between HLA typing laboratory is essential for good bone marrow transplantation program. So what are the different steps in the bone marrow transplantation? So now you understand different types of stem cell, what is matching, and both bone marrow transplantation and hematopoietic stem cell transplantation are same. So next few minutes I'm going to explain what are the different steps involved in bone marrow transplantation. First is selection of the patient, then selection of the donor, then pre-transplant workup for both donor and patient to make sure that they are matched and the patients are fit, there is a correct indication for the transplant, and donors are not risk for the recipient, and they are the best match donor. After that, we need to collect stem cell from donor. Once we collect it, then we need to infuse stem cell into the patient. Before infusing the stem cell, we need to prepare patients and create a space in the bone marrow of the patient by using appropriate conditioning agent, which I explain to you later, at the right combination, so that when we infuse stem cell, there won't be much complication, and that is called conditioning. Once conditioning done, the collected stem cell from the donor will be infused. So the stem cell infusion, it is like a kind of blood transfusion. So after that, there will be regular monitoring and continuous inpatient assessment in bone marrow transplant unit. There will be potential complication during this period. Complication can be due to conditioning agent. It can cause organ toxicity. It can cause pancytopenia. It can cause immunosuppression, and there will be a lot of complication which I explained to you. And there are many measures we can do to prevent infection or complication, and if any complication arise, we may need to manage. Once we infused stem cell, so after 10 to 14 days, we will start looking engraftment. So we will be monitoring for engraftment. Engraftment means the infused stem cell settle in the bone marrow of the patient, and they start developing into new blood cells like WBC, neutrophil, platelet, and hemoglobin. So that is called engraftment. After the engraftment, when there is no complication, patient will be discharged from the BMT unit after 4 to 6 weeks. Then still, even though discharged, this patient will be regularly closely monitored for various complications by transplant physician up to 2 years. So these are the different steps. Now I will go through each one a little bit detail. Selection of patient and pre-transplant workup. As you may know, transplantation carries a significant risk of morbidity and mortality. Pre-transplant assessment, therefore, very important. It will tell us the recipient can withstand the procedure of bone marrow transplantation without excessive risk. Is there any contraindication with recipient? Is the disease status is suitable to undergo the bone marrow transplantation? So the result of this pre-transplant assessment will also help to decide about transplant modality, like what kind of conditioning regimen we use, type of graft, stem cell source, and post-transplant strategy. Pre-transplant assessment include assessment of the disease, what are the status of leukemia, whether patient is in remission, or what are the ferritin level or iron storage in the liver in case of thalassemia major. So all these things need to be assessed. Disease status, HLA typing of the patient so that we can search for the best donor, and blood tests which include virology like CMV virus, EBV virus, adenovirus, radiology test which include X-ray, maybe CT scan, cardiac function assessment, echo, pulmonary function test, renal function test. So all these tests will be done to make sure patients are fit to undergo this bone marrow transplantation procedure. So in general, what are the indication in children where we do bone marrow transplantation? In the case of cancerous condition, leukemia, both AML and ALL can be treated with bone marrow transplantation. Again, all the AML or all the ALL doesn't need bone marrow transplantation. Most of them can be cured with chemotherapy. However, if it is relapse or refractory, there is a clear protocol when to do bone marrow transplantation in AML and ALL and CML. CML means chronic myeloid leukemia. Other cancerous condition, lymphoma, again, most of the lymphoma in children can be cured by chemotherapy. If it is refractory, relapse, we use autologous stem cell transplantation in the case of lymphoma. MDS, like juvenile myelomonocytic leukemia, the choice of treatment is bone marrow transplantation. Other cancerous condition in children, solid tumors like neuroblastoma, medulloblastoma, or refractory or metastatic Ewing sarcoma. In this case, we use autologous stem cell transplantation. The reason is all this condition, bone marrow of the patients are healthy. However, we use very high dose to destroy the existing cancer. So because of the high dose which destroy healthy stem cell or bone marrow of the patient, we use or we back up stem cell of patient and store it. After the high dose chemotherapy, we use this stem cell as a rescue treatment. It is also called high dose chemotherapy with autologous stem cell rescue. Non-cancerous condition in children where bone marrow transplantation is used include genetic disease like primary immunodeficiencies. There are more than 200 primary immunodeficiency. Most of them can be cured by bone marrow transplantation. For example, severe combined immunodeficiency. These kind of kids will get recurrent infection. Without transplantation, it cannot be cured. Therefore, in the case of children having different types of primary immunodeficiency, only curative option is bone marrow transplantation. There are inherited metabolic conditions where we can use bone marrow transplantation. Benign hematological condition like aplastic anemia, pure red cell aplasia, also called Blackfan-Diamond syndrome, Fanconi anemia. In this case, we can use bone marrow transplantation, and especially in aplastic anemia, if we use matched sibling, the rate of curation is very high, even up to 90%. Other condition is thalassemia major and sickle cell disease. There are different criteria in each condition to decide when to do bone marrow transplantation. And another thing, I have seen people have done bone marrow transplantation in the case of severe juvenile chronic arthritis. It is a autoimmune disease. Again, in bone marrow transplantation, what is happening? We are replacing stem cell of blood stem cell, which is the mother of immune cell. So in autoimmune disorders, in severe case, we can also use stem cell transplantation as a curative option. So now we understand there are different conditions we can use bone marrow transplantation. However, we have to do a lot of pre-transplantation workup to make sure patient is fit for transplantation and patient has got correct indication. Once we selected the patient, we also select the best donor. Once we have donor as well as the recipient decided, the next thing is we need to start actual processing of transplantation, which include admission of the patient in bone marrow transplant unit and prepare the patient to receive stem cell infusion. So, preparation of patient in the transplant unit is the most important thing is administration of conditioning agent. Conditioning agent include, it can be combination of chemotherapy, it can be radiotherapy, it can be immunotherapy like Campath. So this conditioning agent eradicate any existing cancer in the body. It will also destroy immune system of the patient. It will also create a space in the bone marrow of the patient so that when we infuse donor healthy stem cell, it will go to the patient and settle there and start multiply, develop into new blood stem cell, which include WBC, platelet, and RBC. So when we decided to do the transplant, so we admit the patient in a bone marrow transplantation unit for the conditioning initially. At the same time, we also collect stem cell from the donor. The collection of stem cell from the donor is called stem cell harvesting. So as I said before, there are three sources of stem cell. One is bone marrow, second is peripheral blood, third is cord blood. So in the case of bone marrow harvesting, what we do is the best match donor under anesthesia. It is similar to bone marrow aspiration. We put the needle into the back of the iliac crest and aspirate a required volume of bone marrow from the donor. So there is a measurement, depends on the weight of the child and how much stem cell we need. We collect the bone marrow and store as we store in the case of blood donation. If we are collecting stem cell from the peripheral blood of the donor, it's called peripheral blood stem cell harvesting. For doing peripheral blood stem cell harvesting, we need a special machine called apheresis machine. So what will happen, as you know, blood stem cells stay in the bone marrow. Usually, if you check your peripheral blood or my peripheral blood, we don't see stem cell in peripheral blood. However, we can see stem cell in the bone marrow. So if we want to collect stem cell from peripheral blood, what we do is we give an injection of GCSF to the donor. This GCSF mobilize stem cell in the bone marrow into the peripheral blood of donor. So after 3 to 5 days of administration of GCSF, the stem cell in the bone marrow will come out into the peripheral blood of donor. So from the machine, they connect to the blood vessel of the donor and blood will start going through the machine. This machine, what they do is they select only the stem cell in the peripheral blood of the donor, and whatever the remaining blood, the machine will give back to the donor. So it is a day-case procedure. It's called peripheral stem cell apheresis. So the machine will collect only the stem cell. Whatever the collected stem cell, we can measure what is the quantity of stem cell. It is also called CD34 count. So once we collected enough stem cell required for the patient, we will stop the procedure, and it is a day-case procedure. Usually it will not cause major complication for the donor. And giving 5 doses of GCS also will not cause long-term complication. So usually donation of stem cell is a very safe procedure, not only short-term but also for the long-term. So once we collected, the patient is in the bone marrow transplant unit. So this stem cell can be infused within 48 hours, usually within 24 hours. We can keep this stem cell usually up to 72 hours in a normal blood storing fridge. That is usually 2 to 6 degrees. So once we have infused stem cell, it is like another blood transfusion. Once we have infused, then by the time patient will be in the bone marrow transplant unit after few days of giving conditioning agent, then during this time patients will be very immunocompromised. They can have various complications, organ toxicity because of the conditioning agent, and very susceptible to infection because of the immunosuppression. So the most important thing during this first 2 weeks is regular close assessment and prevent complication and manage complication if anything developed. By about 10 to 14 days, usually we will see is there any signs of engraftment. What is engraftment means? Whatever the stem cell we infused, it will settle in the bone marrow of the patient and start developing into new blood cells. So the definition of engraftment means if you get 3 consecutive days of neutrophil more than 0.5, platelet more than 20, and hemoglobin more than 80 without blood transfusion support, we call this engraftment. There are different way of testing it. It's all called chimerism. We can precisely test how much percentage of donor stem cell in the patient or in the recipient. So once engrafted, still there are potential to have complication, especially infection, both bacterial and viral. Therefore, usually 4 to 6 weeks, this patient stay in isolated room in bone marrow transplantation unit. After engraftment, if there is no complication, especially we will also monitor for GVHD, which is one of the common and very challenging complication during transplantation. So once engrafted, patient will be discharged. However, there is a need of regular, very close follow-up on outpatient basis to look for infection, to monitor virus status and other complications. So in conclusion, bone marrow transplantation are very well used in many conditions in children, which can be curative for many conditions. However, BMT, bone marrow transplantation, carries very high risk of morbidity and mortality. Careful selection of both patient and donor, we can reduce mortality and morbidity. Intensive monitoring during BMT and regular follow-up after transplantation are very important. Thank you very much. I hope you have understand some basic of bone marrow transplantation in children. Thank you once again.